Good evening, all the aspirants present here. Today topic is domain renal, and the speaker that we have here today is Dr. Nikhilesh Jain, who is a director and operational head depth of critical care services care at CHL Hospital Indore. All the students are requested to hereby drop the question in the chat box. During the Q&A session, we'll be answering those. And please, everyone is requested to mute their mics. Thank you. Sir, please start your session.
Today we'll be doing, certain questions on renal domain. And these questions would later on be, they are more case-based. And once we are done with them, then there would be a brief discussion somewhere later on in the debriefing part. So this is the first case, you've got a 34-year-old male who presents to the emergency department with severe muscle pain, dark colored urine, and generalized weakness for the past 24 hours. Now, he reports completing an intense CrossFit workout 2 days ago, which included multiple sets of weighted squats and deadlifts. He denies any prior history of similar symptoms. So, some more details that may be given to you would be when it comes to vital signs, BP is 125 by 80 mm of mercury, heart rate of 98 beats per minute, temperature of 37.3 degrees centigrade, and respiratory rate of 16 beats per minute. On general examination, he's alert and oriented. He appears uncomfortable due to muscle pain. From a musculoskeletal point of view, you have got a bilateral thigh and calf tenderness with mild swelling. Neurologically, there are no focal deficits. Your DTRs or the deep tendon reflexes are normal. Elevated serum myoglobin levels and serum creatinine levels are noted, with a low urine output probably going towards the range of an oliguric range. So I guess most of you would have got the diagnosis by now, right? And can you just put in the chat box, what do you think this is? In the chat box, I don't want to open everybody's mics. This is correct. Pawan has given the answer, and this is what I think most of you should have been able to get it. This is indeed rhabdomyolysis. And when we look at the questions that can come out of this, the first question would always be, what is the diagnosis? Then second one would be listing of the electrolyte abnormalities which are commonly seen. This could be all your hyperphosphatemias, potassium, calcium, uric acid, these disorders, which are commonly noted in rhabdomyolysis. Then what would be the diagnostic test? That would come next. Whether you would attach credence to clinical symptoms alone, whether you would attach credence to myoglobin levels alone, whether you would attach credence to proper history, whether there is a diagnostic algorithm to that, that all would be covered in that. Of course, the next thing would be what would be the role of urinary alkalinization in that. Can anybody say anything in this? These are fairly standard questions. You can again put it in the chat box. So what is the diagnosis is done and finished. Then you have to list what are the electrolyte abnormalities which are commonly seen in rhabdomyolysis. Now, let me tell you, this can happen in different stages as well, in terms of what stage of rhabdomyolysis you are seeing. So that needs to be remembered and sorted out. And of course, the diagnostic test, as I told you. And what would be your differential with that? So that is how you would like to differentiate it with hemoglobinuria. You would like to differentiate it with maybe anything else. So what would be, but the most prominent thing that I would like you to differentiate it with would be either RBCs in urine, that is hematuria, or hemoglobin urine, right? Then comes a question on role of urinary alkalinization. Is there a role or is there no role? Or maybe a limited role in certain settings, right? So this would be again taken up during the debriefing part. And what are drug-induced causes for the same? This would be a list wherein you would be actually doing certain drugs that would be causing rhabdomyolysis. Can anybody put some of them in the list? Okay, that is one. What else? Statins are one of the commonest drugs that are being prescribed nowadays. Anything else? Antipsychotics. What next? Okay, so I've already got some of them in the list. And as it goes on, uh, again, this would be discussed in detail during the debriefing session. Then you need to list the complications of the above. Now, what are the complications? Sometimes people can get confused, but complications meaning what all can it give rise to? It can give rise to DIC. It can give rise to multiple other organ dysfunctions because of metabolic acidosis. So all those things need to be mentioned in that order, right? I'll go on to the second case vignette now. So this is case 2, 72-year-old male, history of hypertension, type 2 diabetes mellitus, chronic kidney disease. You've got a CKD stage 3. And this male presents to the emergency department, ER, with chest pain radiating to his left eye. It was found that this guy has coronary artery disease, and they performed an urgent coronary angiography with contrast on him. His past medical history included hypertension, type 2 diabetes with an HbA1c of 7.8, CKD stage 3 with a baseline creatinine of 1.6 milligram per deciliter. And the medications that he was on included metformin, lisinopril, aspirin, and atorvastatin. He did not have any allergies. And in terms of recent procedures, he had undergone a contrast-enhanced CT angiography 2 weeks ago. So some more details about the same. Vital signs included BP of 138 by 84 mm of mercury, heart rate of 76 beats per minute, respiratory rate of 18, temperature of 36.9 degrees centigrade. General examination, no distress, alert and oriented. Cardiovascular, no murmurs, no signs of heart failure. From a renal point of view, there was no costovertebral angle tenderness. There was a mild bilateral lower extremity edema. 48 hours after the coronary angiography, the patient reports decreased urine output and generalized. Now, the baseline creatinine, which earlier was 1.6 milligram per deciliter, goes up to 2.3 milligrams per deciliter, which is a 48-hour increase of 0.7 milligram per deciliter. BUN, that is the blood urea nitrogen, was 38 milligram per deciliter, which was elevated. The patient develops mild hyperkalemia, urine allergy, and on urine routine examination, this patient has muddy brown casts with no protein. Can I have the diagnosis again in the chat box? What do you think is happening here? This is simple. Can you give me the answer in the chat box? Yeah, this is fine. This is fine. So somebody has mentioned it. This is basically contrast-associated kidney injury. It is no longer rhabdomyolysis with hyperkalemia, Pika. And Sanjay has told correctly, it is contrast-induced nephropathy or maybe a contrast-associated kidney injury. And so what is the diagnosis? Yes. Now, can you establish a causality for the same and what are the risk factors? So we need to mention what are the risk factors which will predispose an individual to developing a contrast-induced nephropathy. And whether is there in current era and current literature, is there a direct causality that can be established in terms of worsening of kidney function happening directly and purely because of the contrast-associated injury? That is one. Then you need to enumerate whether there are any risk prediction models. There is one actually, and you need to mention it. What are the certain variables that may be included? Now, when it comes to prevention, of contrast-induced nephropathy. Of course, everybody knows about hydration, and of course, everybody knows that N-acetylcysteine may not work that well, but certain specifics of the same, um, a little bit about vitamin C, a little bit about bicarbonate, all these things should be something that you should be able to mention. Then any correlation with contrast agents, you need to tell everybody whether what type of contrast agents are more likely to cause it, and how do the isoosmolar or normosmolar isoosmolar contrast agents fare in giving rise to a acute kidney injury. So again, this would be discussed a little bit in more detail about during the debriefing part.